welcome back. If you are able to hear, you can tell yes so that we can start the session. Yes, thank you. What time class will end? I'll take another 1.5 hours maybe, and I'll stop the session. So that's all about today. I think, this is a revision session and we have very limited time. That's why I have to go pick up the pace at one point. So that's why I need to pick up pace, isn't it? I think the last session, of course, it is better. It's power packed. Whatever is needed, whatever you need it, I've told. So that's what this is all about. So now let us move on to the other parts of neurology. The first one, we'll start with the headache and we'll go into the brain again. The most important points with regards to headache. We're not going to talk everything about headache. Let us go to the most important points about headache. So headache, we have many different types are there. One is the basic, the primary type of headache, and we have the secondary type of headache. Of course, the primary is going to be the most common. In the primary type of headache, your tension type headache is going to be the most common, of course. And not only the tension type headache, we have migraine as a primary headache. Then we have other types of headache like trigeminal autonomic cephalgias. Trigeminal autonomic cephalgias, we typically tend to call them as TACs. We'll be discussing after some time. Then we have something called a hypnic headache. Then we have something called a medication or use headache. That's called a MOH. RS ever to as a medication or use headache. So migraine, tension type headache, trigeminal autonomic cephalgias, hypnic headache, medication or use headache. And secondary headaches, it can start from sinusitis to it can go to stroke, especially your hemorrhagic kind of a stroke, or it can be trauma, or it can be a space occupying lesion. It can go to idiopathic intracranial hypertension, CVT. So like many causes are there. Yes, of course, infections, meningitis, brain abscess. So many causes are there. So we cannot really, come into a conclusion. What is the cause of a secondary headache? Secondary means it's underlying a secondary disorder. You can write a subarachnoid hemorrhage also. Fine, all right. So many headaches are there. So all these things will come under secondary headaches. Remember the most important question is whether you need MRI or not. That's the most important question as far as exams are concerned. So if you know clearly it's a primary headache, no MRI required. So typically for primary headaches, you don't really need an MRI. But on the other hand, if you wanted to rule out a secondary cause, you may need an MRI. So start with, you need to know, for diagnosing a primary headache, you don't need MRI because primary headaches will not show any MRI findings. No characteristic MRI findings is there in primary headache. So that's not going to be really helpful. But why you do a MRI? So that is only to rule out a secondary cause. If your features are favorable of a secondary cause clinically, so the clinical prediction is favoring a secondary cause of headache, then in that setting, you might be needing a MRI sometimes. But the most important point to be noted in exam is any elderly, new onset headache. What do you mean by elderly? Which means anyone who is beyond 50 to 55 years of age and the patient is having a new onset headache. Yes, definitely you need to do an MRI because here the unequivocal diagnosis that has to be ruled out is the tumor. Very common. So that is why any elderly new onset headache, definitely you need an MRI. But whether you need an MRI or not, you have to take it very, in a very cautiously with a pinch of salt, because typically MRI is not going to show any finding in a primary headache. But to rule out a secondary cause, if you need, you can do an MRI. But for secondary causes, if it's clinically warranted, for all patients, you can do an MRI and find out what is actually going on, especially in setting of space occupying lesion or IH or CVT, whatever it is. So number one. So now you know what do you mean by primary headache and what do you mean by a secondary headache. So first, most important thing what they'll be asking you in exam is the difference between a migraine and basically a tension type headache. So they'll ask you how to differentiate between migraine and tension type headache, because this will tell you the features of a tension type headache also. Migraine is basically given by an age-old mnemonic called POUND, where P stands for its pulsatility. So migraine will be basically pulsatile. It will be typically of approximately 1 day duration, but the duration ranges from 4 to 72 hours. But average it will be of 1 full day. Typically unilateral, but it can be bilateral. Usually associated with nausea, but vomiting is rare. Usually associated with nausea, which is one of the important migrainous feature. Then of course this headache is disabling, which means with migraine you cannot be able to do anything else, which means you will be needing to just sit in one place, relax, sleep in a peaceful room. So that's what the patients are going to do if the patient is having a migraine. So it's going to be extremely disabling and it will disturb you from doing your work. So that's migraine. It's exactly opposite to that of tension type headache. So tension type headache generally tends to be non-pulsatile in nature. Yes, the duration is quite variable, but it will usually be only for a few hours, not more than that. And headache is typically bilateral and it will be like a band-like headache. For a good reason, you can remember that Roger Federer brand. Roger Federer usually and Rafael Nadal, everyone used to use a band, isn't it? Many of the football players also have a band. So it's going to be like that, band-like distribution of the headache. So that is typical tension type headache. And you will not have any nausea, no migrainous features, and it's completely a non-disabling headache, which means even with the headache, many patients will be going about it. Nadal also uses, I think in the recent tournament I've seen Nadal also using a band. Anyways, Federer definitely uses it. So everyone knows Federer who uses the band. Okay, so it's a band-like headache, usually bilateral, not associated with nausea, and it's a non-disabling form of a headache. And more importantly, tension type headache is more common when the patient goes towards the evening, because you can imagine like the stress and office tension, everything is going to be maximum in the evening. So the tension type headache typically happens more in the evening. And band-like means it will be from the frontal region to the occipital region, bilaterally like a band. So this is very characteristic feature of a tension type headache. Basically, tension type headache is typically due to stress and neurotransmitter imbalance in the brain. Mostly, the treatment is de-stressing, which means you have to de-stress the patient by psychological counseling. Number one, plus or minus you can use some short-term analgesics to treat a migraine. So that's all needed. I'm sorry, for tension type headache. That's all needed for a TTH. Very common type of headache. In fact, the most common type of headache in the world is TTH, and the most common type of primary headache is also tension type headache only. Evenings, band-like, frontal region to occipital region, bilateral, non-pulsatile, no migrainous features like nausea, and patient will have a non-disabling type of headache. But it's a very annoying type of headache. So that's TTH, very classic. And as far as the migraine is concerned, we know how migraine is going to be. So migraine is going to be extreme. Yes, migraine is going to be extremely depressive. And there are two different types of migraine that you need to know. One is called as migraine with aura, and second is migraine without aura. So the migraine with aura is what we refer to as something called a classic migraine. And migraine without aura is what we refer to as a common migraine. As the name suggests, migraine without aura is common, which is typically referred to as a common migraine. That's the most common form. Almost 70 to 80% of the migraines will be coming without aura. And that's why it is called as a common migraine. Classic migraine with aura is not that common, 10 to 20% of the patients only. And more importantly, if somebody asks you what is the currently accepted pathophysiology as far as migraine is concerned, you'll be answering with one word, that is called a cortical spreading depression. Cortical spreading depression. So that is the most accepted hypothesis currently for migraine. The vasoconstriction hypothesis that we have been using previously have not been found to be very accurate. We feel now currently that this cortical spreading depression is basically the single most important reason for development of migraine. This theory tells, if you take this is the frontal region, and this is the occipital region, Sylvian fissure, and there is a depression that spreads from the occipital region to the frontal region. This is a way of depolarization, very slow way of depolarization. Usually takes around 30 minutes to 1 hour to go from occipital region to frontal region. So this kind of cortical spreading depression is thought to be the reason for development of the migraine. Why they develop cortical spreading depression, we don't know. That there will be a lot of underlying genetic reasons for that, which have been currently validated. But nevertheless, this is the reason for development of the migraine in the first place. How this is going to result in the development of the migraine? Because this will result in stimulation of the trigeminal nerve heads, most importantly. So for example, you can take the CN5 stimulation. So in the brainstem. So, you know, there are vessels, blood vessels that are also innervated by the trigeminal nerve. So what happens is, because this cortical spreading depression activates the trigeminal nerve, it is believed that this trigeminal nerve, in response to that, releases some important mediators, and one of the important mediators, frontal occipital, occipital frontal, occipital region to frontal region, back to front, occipital region to frontal, not frontal to occipital. We are talking about a depression, not the headache. So headache in your tension type headache is your band-like headache, frontal to occipital region. But here we are talking about a cortical spreading depression that is starting from the occipital lobe towards the frontal lobe. So during that time, they're going to activate the trigeminal nerve, and trigeminal nerve is going to release a lot of substances, and the most important is going to be two. One is called the substance P, and another is CGRP. And these are vasoactive substances, meaning they are going to cause vasodilation. And once they cause vasodilation, there is going to be exudation of substances back into the extracellular surface, into the interstitium. This exudation of the substances from the vessels is going to activate the trigeminal nerve heads again. These trigeminal nerve endings one more time. There will be a double activation of the trigeminal nerve endings. One by the cortical spreading depression, and second by the substances that are coming out of the vessel. So this kind of double activation of the trigeminal nerve will result in extreme hypersensitivity of the trigeminal nerve in picking up the stimulus. That's what is thought. So for example, even a non-noxious stimulus like pulsations of the vessel now will be triggering the trigeminal nerve to perceive them as painful stimulus. So that is why that kind of pulsatile headache classically, even the vascular pulsations will be now heard by the trigeminal nerve, or now will be sensed by the trigeminal nerve as some noxious stimuli. That is because of extreme hypersensitivity of the trigeminal nerve to the sensory stimulus. So this is what is thought to be the reason for the development of the migraine in short. That is the reason why the corner molecule, and the most important molecule as far as the migraine pathophysiology is concerned, is currently thought to be due to the CGRP, that is calcitonin gene-related peptide, and that is the reason why a lot of CGRP antibodies are currently available in market. And you can remember this as a type of an allodynia, which means where the relatively non-noxious stimulus is basically sensed as a noxious stimulus. And we know what are the CGRP inhibitors that are currently approved. One, of course, the famous drug that's called erinumab. And we have something called a galcanezumab. Clear? I think galcanezumab, not galacanezumab. Galcanezumab. And there are many newer CGRP inhibitors are also available, but for, I think in Indian practice currently what is available in the market is erinumab right now. It is already available in the market. So I think it's better to remember at least that particular drug for exams. Then what will be the clinical features of migraine? In short. So let us tell with aura, and next is without aura. So as far as with aura is concerned, you're going to have certain set of rules to diagnose with aura. This is a classical migraine. So usually by general, you should have at least 2 attacks. At least 2 or more attacks is necessary to tell with aura. And remember, the previous vasoconstriction theory did not account for the aura. We really didn't know why aura is happening. But the current theory, the cortical spreading depression, accounts for the aura as well, because the same cortical spreading depression can result in the development of aura. So that's why, this theory is very helpful. And at the same time, this theory is more relevant. Why? Because previous vasoconstriction hypothesis or vasodilation hypothesis, whatever you believe, will not explain why the drugs that we use, vasoconstrictor drugs that we are using like triptans, is not going to treat the aura. The aura will not be treated by triptans. Only the headache will be treated by triptans. So now we have evidence for all those things. So this is the cortical splitting depression, and that is the reason for development of aura in the migraine, and that is serving as a principal reason for the development of migraine in the first place. And that led to the, like understanding that CGRP as a key molecule for the development of migraine, and that is why our understanding of pathophysiology has improved, so that the treatment has also improved to a great extent. So to diagnose a migraine with aura, you need at least 2 attacks of migraine with aura, and they should have an aura. I'll tell you what are the auras the patient might get. Plus, at the same time, any one of the following. Like for example, if the patient is having an aura that is fully reversible. If an aura is happening that is not fully reversible, it could be a transient ischemic attack or even a stroke. Then you have another finding. Then not anyone. So all of the findings. So you have A here, aura that is fully reversible. Number 2, unilateral progression of symptoms. The headache will be unilaterally progressive, and the symptoms also will be unilaterally progressive over a period of 5 to 60 minutes. So which means within the first 60 minutes, the patient will get the full attack. So the headache will start after that. The aura will progress. And usually, as I told you, the headache will start within 60 minutes of aura. Headache that will start within 60 minutes of aura. So this is the characteristic feature of migraine with aura, and one of the diagnostic criteria for diagnosing migraine with aura. Then we have migraine without aura also. Based on the definition, you should have at least 5 attacks for diagnosing migraine without aura. Plus, patient should have some migrainous features. And remember, each attack will be lasting for approximately 44 to 72 hours, which I have described already. Plus, patient will have some form of migrainous features. What do you call as migrainous features? Patient will have nausea, but very rarely vomiting. Very rarely vomiting. At the same time, patient might have some features like photophobia or phonophobia, which means on hearing the sound, they will get extremely irritated, and seeing the light also, they're going to get extremely irritated, photophobia or phonophobia. At the same time, most of these attacks will be unilateral, pulsatile, which you have seen already, and it's going to be of moderate to severe intensity. It's not never mild. Migraine is never a mild attack. So moderate to severe intensity of headache. Clear? So this is how you diagnose a migraine without aura. Simple, isn't it? So remember, both are same only, but the number of attacks differ for diagnosing. At the same time, headache happening within 60 minutes of aura is an additional criteria here, but here there is no criteria like that because there is no aura here. So migraine with aura, let me repeat because these two have been asked in PG exam once. So migraine with aura, 2 attacks. You get an aura that is fully reversible, unilateral progression of symptoms, and in 5 to 60 minutes, and headache that is going to develop in approximately 60 minutes after development of aura. And as far as the migraine without aura is concerned, you need at least 5 attacks, each attack lasting for 4 to 72 hours. There will be some migrainous features like nausea, vomiting, photophobia, or phonophobia. Apart from that, there will be unilateral pulsatile, moderate to severe intensity headache. So this is migraine without aura, classically. Then what are the types of aura that you can get as far as migraine is concerned? So there are many different types of aura. So can you tell me some important types of aura and the most common types of aura? What are the most common types of aura that you get in migraine? First thing, everyone telling zigzag, flash, everything, but first you have to know that visual auras are more common. As a clinician, this is what it's important for me. Visual auras are going to be the most important as far as migraine is concerned. And the most that's going to be the most common, and the usual characteristic visual aura that we get is something called a scintillating scotoma. Scintillating scotoma. And a classical description is there. As far as scintillating scotoma is concerned, there will be usually peripheral zigzag and a bright, or you can tell like a kind of like a blurred area will be there. Bright, blurred, zigzag body will appear in some corner of the visual field. On one particular area of the visual field will happen. Mostly it can be monocular also. And slowly that will start enlarging in that particular visual field, in that particular eye. It is starting to expand slowly. And at one point of time, it will be obscuring the maximum amount of visual field and you will not be able to see anything in that particular eye. Suddenly it collapses into nothing. So this is basically what we refer to as a classic scintillating scotoma. This is what the patients describe. And that's a very important thing. So this is a zigzag appearing, bright, blurred area that obscures the visual field, not be able to see beyond that in a visual field in a particular eye, because it's unilateral most of the time. So slowly, it expands, and it completely obscures the visual field in that eye. Suddenly it collapses into nothing. So this is typically a scintillating scotoma. And that is the most common and the classical type of like aura that you get in the migraine. So this kind of symptoms, this kind of scotomas are actually referred to as positive scotomas. Why they are called as positive scotomas? Because this is some new thing that you see basically. If you get a negative scotoma, which means you will not be able to see anything in that area, that will be a blackout completely. Nothing will be seen in that area. So if you see a blackout sort of thing, that's a negative scotoma. But if you see this kind of a zigzag line, some shining light kind of a thing, so if you see, that is basically a positive scotoma. This is also scotoma, it obscures the visual field. Isn't it? Anything that obscures in the visual field is what we call it as a scotoma. And this is a type of a positive scotoma. This is very important to differentiate, because in TIA, transient ischemic attack, you're going to get something called a negative scotoma and not basically a positive scotoma. And patients can develop sensory auras also. For example, a few patients may get this kind of pins and needle sensations, but remember, usually they will get only in the upper limb, and getting in the lower limb is extremely rare. And usually whenever you get a sensory aura, it will be associated with your visual auras also. It is very rare to get a sensory aura alone. Usually it will be associated with the visual aura, 99% of the times. And at the same time, the sensory symptom that you're going to get is a positive symptom again. Not going to get a negative symptom like sensory loss. It will be like a pins and needle or a tingling sensation. So it's again a positive symptom. So when you get a negative symptom like sensory loss, it goes towards a TIA. So that's another important point difference between a migraine and a TIA. And at the same time, there can be other types of auras like olfactory auras, otherwise, and you can get something called gustatory auras, where some new taste might appear, some new smell might appear. Olfactory and gustatory auras very rare. Or they can get auras of body distortion, in the sense like it might appear as if some of their body parts are completely distorted. Like some patients will have a constant feeling during the time of aura. They will have a constant feeling that tongue is swollen, tongue is in the side of the cheek. But in reality, the tongue will be in the center only and will be nicely looking, not swollen. But they will have a constant feeling during the time of aura that the tongue is swollen. So that's called auras of body distortion. So distortion type of auras. Anyways, but the most classical and the most common is going to be the visual auras. That's what they're going to get. And it's very important to differentiate this migraine from a TIA. If somebody asks you how will you differentiate migraine from TIA, the first thing is here it's positive symptoms, here it's negative symptoms. That's the most important thing. Where in migraine, typically you will get sensory augmentation like tingling and this kind of pins and needles kind of sensation. And at the same time, whatever the auras you get, even visual, everything will be positive. Whereas in TIA, you will get more of an amaurosis fugax, negative, a blackout, a negative kind of a scotoma, and a sensory loss, numbness. Again, it's more of a negative kind of symptom. So that's the most important difference. If I want to tell in one single word, migraine will usually have a very slow progression. It will take 1 hour, 10, 15 minutes. But TIA will be having extremely fast progression. Everything will happen within a period of 2-3 minutes. It can last for 5 minutes, 1 hour, 2 hours, but the progression will be extremely fast. 2 minutes, there will be a complete blackout because it's an obstruction to a particular vessel. So that's transient ischemic attack. And apart from that, we know that migraine is very common in younger population, whereas in older age, mostly I will go towards a diagnosis of a TIA rather than a migraine. And of course, headache is a very, very important sign, and almost every single patient, 100%, all the patients will have a headache after the aura. And remember, aura will completely resolve before the onset of headache, which means at the time the patient develops headache, almost there will be zero aura. The aura will be lost completely. But here headache is rare. It can be still there. Headache can still be there, but only 25%, not 100%. But it's very rare to have a headache. 21 in 4 can have a headache, but the patient can have headache and TA both together. It means like aura and headache may not happen together. That's an extremely rare scenario. But whenever headache and that symptoms are there together, I usually goes towards a TA. Both can come together. But in migraine, usually initially it will be an aura, then followed by a headache. By the time you get the headache, the aura would have disappeared by that time. So which means these patients know already, once they get that kind of symptoms, they're going to get a headache. So they know that they can actually identify that. That's why I generally ask the patients whether you have any premonitory symptoms that you will get a headache. So if they tell yes, I do have this premonition. If I get this, I get a headache. That is very likely to be a migraine. And this kind of history usually is missed by many of the practitioners. That's a very common history. The patient knows that they will get a headache. They will have that kind of intuition, which means they'll get that kind of sensory symptoms. They'll get that kind of, like some visual symptoms, and followed by that, surely they will get a headache. So this is migraine with aura. Very easy to diagnose in practice. But migraine without aura is very difficult to diagnose because it is completely diagnosed based on clinical rounds. Many of the times, migraine without aura is diagnosed as tension type headache, and tension type headache is diagnosed with migraine without aura. But overall, as per the survey, migraine diagnosis is mostly underdiagnosed, which means there are a lot of migraine cases in the community, but you tend to underdiagnose it rather than overdiagnose. You miss a lot of cases of migraine. And you have many variants of migraine. Apart from these two classic types of migraine, two types of migraine which I have discussed, there are a lot of variants of migraine. For example, the first variant is something called a FHH. Everyone would be aware of that. That's called a familial hemiplegic type of a migraine. So usually it is autosomal dominant in inheritance and tends to happen in young adults, especially in teenage group, young adolescents, young adults. They are the ones who are going to get this kind of familial hemiplegic kind of a migraine. So I'm not writing FHH. I should write FHM, isn't it? In urgency, I wrote FHH. FHH is familial hypocalciuric hypercalcemia. That is different. That is in calcium metabolism. We are talking about a familial hemiplegic migraine. FHM, autosomal dominant disorder, which is going to happen in young adults. So what is going to happen in these patients is they're going to get a headache first. After this headache, they'll be getting a transient hemiplegia. It's not a TAA, trust me. They'll get a transient hemiplegia after the headache. Usually, they will get after some around 30 to 60 minutes, which means after half an hour to 1 hour, they'll end up in a transient form of hemiplegia, which is actually completely reversible most of the times. So this is what we refer to as a familial hemiplegic migraine. And more importantly, the headache that you're seeing usually will be locking on the side of hemiplegia. That's very important because the headache you'll be getting in one side and hemiplegia you'll be getting in one side. So both will be usually similar. It can be right means headache will be on the right side, hemiplegia also will be on the right side. If headache is on the left side, hemiplegia will also be on the left side. So usually there will be a locking of the headache and hemiplegia on one side, but it can be variable. Next time they can get left side also. But most of the times, whichever is the side of the headache, that is the time where that is the side where they're going to hemiplegia. Transient in the sense it will be less than 24 hours. It will not be extending for more than 24 hours. We all know as per the traditional definition of stroke, more than 24 hours is what we call it as a stroke. So according to the traditional and the WHO definition, this is not going to be fitting under the criteria for stroke. So it's not a stroke basically. So it is unlikely to be a stroke. So this is a familial hemiplegic migraine, remember, and it is completely reversible. So that's the most important point. It's not, there is no residual defect in this kind of individuals. And second, we have something called a basilar type of a migraine. So what is basilar type of migraine? Typically this happens in children, very young children of age 5 to 10 years. This is where you're going to get a basilar type of a migraine. So here, usually there will be an aura. So familial hemiplegic migraine, generally they don't have an aura, but basilar migraine, usually they have an aura, which will last for less than an hour. This aura will be followed by a headache. We know that whenever you get an aura means it should always have an headache. After this headache, most of the time they used to develop this posterior circulation stroke-like symptoms. For example, they will get visual field defects. For example, they will get hemianopia, or they can have a complete blindness also. It depends. The severity depends, but they'll get either a visual field defect or they can get a complete blindness. Apart from that, they can get vertigo, dizziness. Even they can get diplopia because of cranial nerve involvement, and they can get ataxia. All these are typical posterior circulation stroke features, and that is why the name came. It is a basilar kind of a migraine. So, very simple. Aura, very common, followed by a headache. Then this followed by a posterior circulation stroke-like feature. All the posterior circulation stroke-like features we have seen already. Ataxia, vertigo, dizziness, loss of consciousness, then cranial nerve palsies, element type cranial nerve palsies. So this is typically a basilar kind of a migraine. And we have something called, third one, that is called a retinal migraine. This is another variant. So what happens in the setting of a retinal migraine? You will get a transient scotoma. It will be usually a positive type of a scotoma or a negative kind of a scotoma because it's a variant. It's not the classic kind of a scenario where you get. So this will be followed by a monocular vision loss, complete vision loss. And this scotoma keeps enlarging, and they'll get a complete monocular kind of a vision loss. And this will be associated with or without a headache. So this is classically retinal migraine, and usually it happens in young adults. So there will be a hole-like scotoma that keeps enlarging, and they will completely obscure the visual field. But remember, it is unlikely to be a TA because it will take over a period of time. It will take at least 30-40 minutes or 1 hour to completely develop into a full-blown monocular vision loss. So, but still, nevertheless, you have to rule out a TA in this kind of a setting. Recently, maybe 2 weeks back, I've seen a patient with a retinal migraine. He's a 24-year-old guy. He's a smoker, all right. That's where the problem is. He came with a kind of a monocular vision loss, complete monocular vision loss. Visual loss reversible. Remember, if you call the word migraine, it will be reversible. So vision loss that was happening only in one eye, and that completely reversed. So he got scared and he came back, and nobody could understand. So we did every possible investigation. We did right from MRI to MR angiogram to the visual evoked potentials on that side. Then we did cardiac screening. We put Holter monitoring to rule out atrial fibrillation. We did everything, whatever is possible we did, but there was no clue. Then what we did is we still thought it's a TA because he was a young smoker. So we sent it with aspirin and a statin. After 1 month, he came again with a similar attack. Within 7 days, he got another similar attack and got admitted. So finally, we thought it's a retinal migraine, and we gave calcium channel blocker, verapamil. It showed a dramatic response, and it's been like the patient did not get at all. So last I've seen him 2 weeks back. So he was completely all right. There was absolutely no problem after starting calcium channel blockers. So that is the beauty of making a correct diagnosis. So whenever you make the diagnosis correct, it's going to respond very nicely. So that's one variant of a migraine called as a retinal migraine. And now we have something called ophthalmoplegic migraine. Ophthalmoplegic migraine. So patient will typically get unilateral third nerve palsy or sixth cranial nerve palsy to produce ophthalmoplegia. And this will be associated with severe headache. So this is what we refer to as ophthalmoplegic migraine, completely reversible again, very common in children. Ophthalmoplegic migraine. So I told you 4 variants. Any one of this can be asked in exam. So familial hemiplegic migraine, basilar migraine, retinal migraine, and ophthalmoplegic migraine. So it's very difficult to find out in exam, but there will be a very big clue in exam in the form of headache, number 1. And second clue will be completely reversible. This is a second clue in exam. And third clue it is slow progression. That's characteristic. It will not have a rapid progression like what you see in a stroke or in a TA. It will be extremely slow progression. And most of the times the patients will be young. That's a big clue in exam. So if you see a focal deficit happening in a young patient, very slow progression, fully reversible, recurrent attacks, associated with a severe headache, definitely you can diagnose a variant of a migraine exam. It's going to be extremely simple. This is the final nutshell and take-home point. And remember, most important point to notice, the routine treatment that you give for migraine should not be used in the setting of a migraine variant, because that might worsen the migraine attack. Because you use something called triptan, you should not use. You should not do that. And similarly, use something called ergot alkaloids. Ergotamine is very common and it should not be used in variant of migraine. In migraine variants, you should use a vasodilator like a calcium channel blocker. That's why I told you that case history also. You should avoid using a routine drug, a vasoconstrictor like triptan or ergot alkaloids, because they can even worsen the attack of migraine, or they can make a neurological deficit complete also. Be very clear about that. TTH completely reversible or not? Yes, TTH is completely reversible. I think you need more information about TTH. If you want, I can tell. I mean, TTH is such a common entity. Suppose if you really want more information about TTH. So TTH is divided into many things. It's mainly due to stress. I mean, based on the amount of TTH, we can divide into infrequent episodic TTH. So where it will be less than 1 day per month. I mean, we'll get only one attack per month in a day. I mean, in one particular day a month. Then we can call it as a frequent TTH. So where you will have at least for 14 days a month. Then you have something called a chronic TTH, where you have more than or equal to 15 days per month. So this is the division of, I mean, tension type headache. Then apart from that, the most important thing is it will be non-pulsatile. In the sense, it will be non-throbbing in nature. And more importantly, I told you short-term analgesics. And if you really want to know, because Shubham is continuously asking like whether TCS will be helpful or TCS will be helpful or not. Yes, it will be helpful. First, I'm going to use simple analgesics for TTH. For example, I'll be trying paracetamol, which works okay. And I can use Brufen, commonly called as ibuprofen. Then I can use aspirin also. Among these drugs, paracetamol is the least effective drug. Generally, it doesn't respond that much. And ibuprofen and aspirin are going to have higher efficacy to abort the acute attack. Or I can use some maintenance therapy also for chronic TTH. I can use amitriptyline. That's what it's been asking for a long time, whether TCS will be effective or not. In fact, this is considered to be the best drug. This is a FDA approved drug for treatment of tension type headache, for a chronic tension type headache. So alternative for amitriptyline is SSRIs. You can use venlafaxine. Venlafaxine is an SSRI. So you can use venlafaxine also. Then apart from that, you have gabapentin, which is equally effective. Then you can use pregabalin, which is also equally effective. Then we can use topiramate also, which is also very effective. But among all this, according to FDA, the most effective drug is amitriptyline only, and these are the 5 FDA approved drugs as far as chronic TTH is concerned. And more importantly, psychological counseling is more important for TTH, because we need to de-stress the patients. Unless we need to de-stress the patients, this is not really going to work that much. I mean, because Shubham has been asking a lot of questions on TTH from the beginning. I've been seeing, that's why I told some more information about TTH, which is a very common form of headache. And now we know that migraine with aura is there, migraine without aura is there. What are the classic auras that you get in migraine, and what are the variants of migraine, and how will you diagnose migraine variants, and what is the differences between migraine versus a TIA. Classic migraine, drug of choice, triptans. Any migraine, drug of choice, if they ask you, it's triptans only, except if you are very clear that you are having a variant of migraine, like basilar migraine, hemiplegic migraine, or a ophthalmoplegic migraine, or a the variant of migraine. So in that setting, you're not going to use triptans. You're going to use calcium channel blockers like verapamil or diltiazem. I mean, usually we use verapamil, but apart from that, all the other migraine, with aura or without aura, the drug of choice is going to be triptans only to abort the acute attack. But for prophylaxis, you can use any drug. For acute attack, if they ask you, you can use triptans. Not a problem at all. So what are the triggers for migraine? There are some basic triggers for migraine. What are considered to be triggers? I mean, I'm not going to write because this is not really worth writing. Everyone knows. Many girls will be suffering from migraine in this particular batch itself. What are the triggers for migraine? You yourself can tell. Okay. more than sunlight, there are some girl-related problems. Of course, one is, yes, hormonal. Okay, menstruation. That's what I want to talk about. Menstruation is a very important trigger. Then lack of sleep. Of course, yes. If you don't sleep properly, then exercise and fatigue. Anything that produces exercise and fatigue, severe exercise fatigue can produce migraine. Yes, Samira is telling alcohol. Okay, alcohol good, correct. Whether it is experience or evidence, I don't know. Alcohol, yes, does produce a headache. Then there are 2 foods which girls like a lot that produces migraine. 2 foods that girls like a lot. Yes, Ling told correct. Cheese and chocolate. Of course, cheese and chocolate are very important triggers. Cheese and chocolate. Then any kind of stress and hunger, exams, or maybe a guy is constantly stalking her. Stress and a kind of a hunger. Hunger is also a very important trigger. So stress, exercise, hunger, chocolates, cheese, then menstruation, fatigue, alcohol, all these are basically trigger for migraine. So anything can cause a trigger. Remember, a girl gets a migraine, but the person who suffers the most is the boyfriend, of course. I mean, any boyfriend of a girl who's having a migraine must be knowing this. So a girl will not be a girl during the time of migraine. And any time when a girl gets a migraine and shouts on you, and please don't try to pacify her. That's the most worst mistake that you can ever do. Maybe you can ask my experience also, maybe possible, but I'm telling you, don't try to convince her or don't try to pacify her if he shouts. That's going to worse. That's going to worsen the condition. So just leave her silently, let her go, sleep in a peaceful room, come back, she'll be much better. And then you can do the romance, no problem. Never try to do anything in a girl who's having an acute migraine, and never try to pacify. That's the most important point. Otherwise, you're dead, literally. And more often, more than the girl who's suffering from migraine, it's the guy who's going to get a lot of things from the girl. Anyway, fine. What are the things that abort the acute attack? So these are called as abortifacient agents or aborting agents for migraine. What are the aborting agents for migraine? The first line agents is, of course, going to be the triptans. There are many different types of triptans. Of course, these are 5-HT1D agonists, which means they are going to work on the vessels producing vasoconstriction. Remember, the more early you give triptans, much better it is. The more early you give, much better it is. The more you give late after the acute attack, it's not going to work. So which means if you give within the first hour after the acute attack, very excellent. It's going to be so effective. Nevertheless, what are the contraindications for triptan? That's very important. As far as I know, the most important contraindication in my practice, I feel, is pregnancy, because many of these will be young girls and you don't know what's their plan. So always ask this, the last menstrual period before giving triptans. Other drugs, I don't care. Very common disease. Before giving triptan, be careful, because in our hospital, Suminat is like everyone takes, like even an IMA takes, like a worker takes Suminat. So that's such a common drug in our hospital. So, but before giving, be very careful, because it's a real-time threat. It's contraindicated in pregnancy. Very important. Then the patient is having a seizure disorder, because it's a vasoconstrictor and it can lower the seizure threshold to some extent. So be careful and don't give in variants of migraine. As I told you, in variants of migraine, you're going to use calcium channel blockers only. Then in patients who are having coronary artery disease, of course, it's a vasoconstrictor. The patient is having a peripheral vascular disease, be very careful. Of course, it's a vasoconstrictor, so you have to be a little careful. And the patient is having a prior stroke or a transient ischemic attack. So in these settings, it's better not to give triptans, and it's better to avoid. And we have a lot of wonderful and beautiful drugs that you can give. For example, there are some alternative drugs that can be of decent efficacy. One is caffeine and paracetamol, which means ask the girl to drink a coffee, which might work a little bit. And paracetamol and NSAIDs. Compared to all these drugs, NSAIDs are much better. Glucocorticoids can work to some extent, and you have metoclopramide. Antiemetics can work. And valproate acutely can work, can reduce, and magnesium in the form of IV Maxelf. Okay, Riju is telling, I will make the coffee for the girl. But what if she throws the coffee on your face because she's irritated? What you will do during that time? Okay, you are very bad, man. You're thinking about, see, I was telling all the drugs that are useful, and you're thinking of making a coffee for your girlfriend when she's in migraine. Okay. Anyways, we forgot one more. Oh, Saurabh is telling better make it cold then. Okay, fine. So one more drug we missed, that is ergot, dihydroergotamine. This is another drug that can be effective. So, right? So these are alternative drugs, but of course the first choice is triptans, but a lot of alternative drugs are there. If you don't assess triptans, you can use. Remember, CCBs are for migraine variants. I told you multiple times. It is not that effective for aborting the usual migraine that you encounter. That for migraine variants, familial hemiplegic migraine, the ophthalmoplegic migraine, basilar migraine, and all this stuff, or retinal migraine. There you use CCBs, not here. And prophylaxis. There are various indications for prophylaxis, but the current standard accepted indication for prophylaxis of a migraine is at least 2 attacks per month. The patient is getting anything more than a couple of attacks per month, or the patient is having a single attack that is lasting for more than 2 days, which means prolonged attacks. Like 2 days, more than 2 days, they are disabled because of the headache. So what are the drugs for prophylaxis? Remember, there is no standard drug that is approved by FDA or any other body to tell that this is the drug of choice for prophylaxis. But I don't know how pharmacology textbooks are coming up with a name called propranolol. But I never feel that propranolol is the most effective. No neurologist also feels that, and no neurologist will start propranolol straight away nowadays. And even though pharmacology textbooks will be coming up with this propranolol as the drug of choice for prophylaxis of migraine, but I don't really believe. We have a lot of other drugs like topiramate, which are effective, especially many girls who get migraine will be a little obese. So you can use topiramate to basically reduce the body weight as well, even though it has a little bit of side effects. Then you have valproate, which can be effective. And you can use gabapentin, which can be effective. Then you can use TCS like amitriptyline, which will be effective. And for example, even riboflavin is thought to be effective to some extent if you give riboflavin for a long time. But I believe, like in certain drugs, I usually use amitriptyline, gabapentin, topiramate, valproate, because it produces severe weight gain. So you have to give valproate very carefully, because young patients, valproate, 2 things. One, it is teratogenic. Number 1, valproate is the most teratogenic antiepileptic drug. We know that 4% risk of teratogenicity. And at the same time, it's going to produce weight gain, hepatotoxicity, PCOS in girls. So many problems. That's why I generally tend to avoid valproate, because of a lot of other issues. But I generally tend to use gabapentin, amitriptyline left and right. Topiramate, especially for girls who are little obese, they can be really helpful. Propranolol I keep as a last choice. Basically, I don't really use propranolol that much. Fine. I think migraine is over. So what are the net take-home points of migraine? That is the differences between TTH and a migraine, very important. Cortical spreading depression, very important. And the newer drugs, that is CGRP antibodies, very important. Criteria for diagnosing migraine with aura and without aura, important. The classic visual aura, that is scintillating scleroderma, many times they will be given in the case scenario, so that's important. Variants of migraine, how to diagnose. I told you overall rule how to diagnose a variant of migraine, important. Treatment is not triptans and it's CCBs. I told you that as well. And difference between migraine and TA, most importantly, it's the positive, negative, slow versus fast progression that's going to differentiate a migraine versus a TIA. And abortifacient agents, first choice is always triptans. There are a lot of other alternatives. Prophylaxis, you can in exam, you can answer for propranolol. So 11 is asking the MCQ drug of choice for prophylaxis of migraine. I don't know who discovered that drug of choice word. I will kill them literally. That is, but anyways, nevertheless, it is propranolol. That's what I will answer, because the pharmacology textbooks are basically given that answer. Nevertheless, okay. So then we have the next group of primary headaches, that is tension type headaches. Trigeminal autonomic cephalgias, TACs, trigeminal autonomic cephalgias. So why the name trigeminal autonomic cephalgias came? Because trigeminal means they are going to be common in the trigeminal nerve region, CN5. But if they ask you most common location within the CN5 is ophthalmic region, so CN51, that's the area where you're going to get this headache in the first place. Then the name autonomic came because they have ANS symptoms, autonomic symptoms, yes. And at the same time, this cephalgia stands for headache. Cephalgia means headache. So which means this patients will get headaches. Maybe I can put a different color. This patient will develop headaches with autonomic symptoms, and very commonly that's going to happen in the trigeminal nerve region. And this autonomic symptoms can be ptosis, and the patients can have meiosis, Horner's-like features. Patients can have lacrimation. Patients can have lacrimation. Patients can have rhinorrhea. And patients can have something called a conjunctival injection. That's called redness of the conjunctiva. That's basically conjunctival injection. So this is what we mean as trigeminal autonomic cephalgia. So you break word by word and you tell what is trigeminal autonomic cephalgia. There are basically many different types of trigeminal autonomic cephalgias, but the most important being cluster phenotype, that is a cluster headache. Then you have the second type of trigeminal autonomic cephalgia, that is a paroxysmal hemicrania. I mean, if you write HC, that is hemicrania. Then you have something called a hemicrania continua. Then finally, you have something called a Sun City. Please, for God's sake, don't ask me to expand that Sun City. That is short-lasting unilateral neuralgiform headaches with conjunctival injection and tearing. That's what we call Sun City. So for time being, let us assume it is Sun City only. Fine. So we need to identify how you're going to differentiate each and everything. Finally, I'll give you a nutshell. Don't worry about that, how to differentiate in exams. But basically, to start with, you need to know about the sex, where you will get the trigeminal autonomic cephalgias. Cluster is very common in males. It can happen in females. If I put male symbol, it doesn't mean it happen only in males. It can happen in females, but very common in males, where there is no sex difference with regards to this hemicrania, paroxysmal hemicrania. And hemicrania continua very common in females. And once again, there is no much sex difference when it comes to Sun City. But more importantly, third type is hemicrania continua. Hemicrania continua. And as far as cluster headache is concerned, this is a usual common question exam. It is common in males, very, very common question exam most of the time. Apart from that, what will be the type of pain? So you can tell the character of the pain. And again, it's very important for us. It will be kind of a boring type of a pain, not like the class that we are going for right now. We are talking about this drilling type of pain, that is boring type of a pain, cluster headache. And typically paroxysmal hemicrania also will have this kind of a boring type of a pain, whereas in hemicrania continua, you will have a throbbing kind of a pain, whereas in Sun City, you will be having a more of a shooting type of a pain or a burning type of a pain, shooting or a burning type of pain. That's what you will get in a Sun City. And as far as the severity is concerned, so cluster headache tends to be extremely severe, very severe form, cluster headache. In the pain scale, you can tell 9 out of 10 or 10 out of 10. Such is the severity of the cluster headache. And that is the reason why cluster headache is also referred by a different name called as suicidal headache. Often patients tend to suicide because of the headache. That's why it's called suicidal headache, because it's extremely severe. In paroxysmal hemicrania, it will be moderate to severe. Sun City most of the time will be mild to moderate kind of a headache. And Sun City, once again, it will be a severe kind of a headache. But the most severe type is going to be the cluster headache only. 9 to 10 out of 10 in the pain scale. And duration, this is a very important difference between these four. As far as the duration is concerned, typical duration is around 50 to 180 minutes, but it won't exceed that 3 hours mark. As far as cluster headache is concerned. Then as far as the hemicrania continuous paroxysmal hemicrania is concerned, it will be around 2 to 30 minutes. There will be a small overlap with cluster headache, but the most important difference between the cluster headache and the paroxysmal hemicrania is the duration. I'll come back to that in some time, where cluster headache will be for relatively more duration, whereas paroxysmal hemicrania will be of relatively lesser duration. Here, you cannot tell the duration because this headache will be continuous in nature. So I cannot tell the duration. That's why it's called as hemicrania continua. So it will be continuous. So if it's a continuous headache, how can you tell the duration of the headache? It's not possible. As far as Sun City is concerned, it can be in seconds, 1 to 600 seconds. It's a sudden, sharp shooting kind of a pain or a burning kind of pain that happens in the ophthalmic nerve distribution. That is in seconds you can describe the pain. So that is Sun CT. And as far as the autonomic features are concerned, all these headaches will have autonomic features. So which means you cannot really tell whether these patients will have, will have autonomic features or not. So every headache is going to have autonomic feature. That's why they are grouped under something called a trigeminal autonomic aphasia. But if you can ask me one question, if it's a hemicrania continua, how can you get autonomic features continuously throughout day and night 24/7? So that is why you need to understand the graph of a hemicrania continua. Hemicrania continua will have a continuous headache on the background like this. They're going to have a continuous headache on the background, which means let us assume a 2/10 headache will always be there, background headache. On top of that, there will be superimposed spikes will be there. That spikes of headache will come. So this is how hemicrania continua will be. There will be background continuous headache. On top of that, they'll be getting spikes of around like maybe 6/10 or 7/10 kind of an headache in the pain scale. So during this kind of spikes, during that time of headache that increase in intensity suddenly, during those time only they will get autonomic features. It's not a continuous autonomic feature. Even though the headache is continuous, the autonomic features will not be continuous. The autonomic features will be there during when the headache becomes very severe. But all the other areas during the headache, definitely they will be having ANS symptoms. And more importantly, one of the important classical feature of a trigeminal autonomic aphasia is they are called as side-locked headaches, which means they'll be strictly unilateral, which means if you get on left side, the headache will always be on the left side. That's the reason why they are also referred to something called as side-locked headaches. You will not get anywhere else. Left side means left side. It's locked. That's all. You will not get anywhere. And the autonomic symptoms will be also on the same side, which means headache and autonomic symptoms both will happen on one particular side only. You will not get in the other side. That's not the feature of the headache. So that's very characteristic feature of the headache called as a side locked headache. It will be locked on that particular side, like a target, how it is locked in times of war. So, then what is the difference with cluster type? So for example, if you take cluster headache, of course, you will get this kind of spikes. Okay. And at the same time, if you get paroxysmal hemicrania, again, you are going to get this kind of spikes only. So if you want to tell one finding that differentiates this hemicrania continua from your cluster and paroxysmal hemicrania, it's the presence or absence of pain-free intervals. For example, in hemicrania continua, there is no pain-free interval. The patient will deny the presence of any pain-free interval. Continuously, they will have a headache. On top of that, they will be having superimposed jabs. But on the other hand, if you take a cluster headache or a hemicrania, paroxysmal hemicrania, there will be definite pain-free interval, what I have marked here. There will be a sure pain-free interval, and only during the attacks they will get the pain. So which means there is a baseline pain-free interval. During the attacks, they will get either a very severe type of pain or moderate to severe type of a pain. But if you still want to differentiate clinically between cluster headache and paroxysmal hemicrania, the only way to differentiate in exam is the severity and the duration, not with any other feature, because both will have almost same kind of headache only. So you cannot differentiate basically. So anything that has relatively more duration, like 1 hour, 1.5 hours kind of a headache, and lesser number of headaches. So you are going to, cluster versus paroxysmal hemicrania. Cluster versus paroxysmal hemicrania. So anything that has a more duration, lesser number, go for a cluster. Anything that has a lesser duration but more number of headaches per day, that is usually going towards a paroxysmal hemicrania. Whereas hemicrania continua, you'll have a continuous headache. There will be no relief of headache. On top of that, you will get the superimposed jabs. So that is hemicrania continua. In paroxysmal hemicrania and cluster headache, you will never have a pain. You will have a pain-free interval in between. But if you want to really differentiate cluster versus paroxysmal hemicrania, the difference will be based on duration and the number of attacks. Duration will be more, number less. That is cluster. Duration less, number more. It is paroxysmal hemicrania. That's the only way to differentiate clinically. Otherwise, it's not possible. Which type is side lock? All the trigeminal autonomic aphalgias are basically side locked headaches. Everything, whatever you are talking right now in this particular table, are basically side locked headaches only. Everything, whatever it spoke now. Then restlessness. Restlessness is again a classical feature of both cluster headache as well as this paroxysmal hemicrania. It's not a feature of your hemicrania continua because headache is continuous. They cannot be continuously restless. So you can imagine like that, and it may or may not be a feature of Sun CT. But in exam again, restlessness is a classical feature of cluster headache. This is very important to differentiate from your migraine, because patients with migraine tend to like go and sleep like peacefully, and they tend to rest. That will relieve their headache. But patients with cluster headache tend to be extremely restless. They will not sleep because sleep is a trigger. I'll come back to that. So patients who are having this kind of cluster headache will be extremely restless, agitated. They'll be moving here and there. That's not a feature of a migraine. So that's one feature that in examiners will expect you to answer in cluster headache. At the same time, what is the number of attacks? Frequency. So I told you cluster will have a less number of frequency, typically 1 to 8 per day, but definitely not more than that. But the classic timing is 1 attack every 2 days. The classic number frequency will be 1 attack every 2 days. In every 48 hours is a classic number that you will get in exam, but it can happen up to 1 to 8 per day. As far as the paroxysmal hemicrania is concerned, the relatively more number, 5 to 40 per day. So clearly in exam, they will give 15 attacks, 20 attacks per day. So whenever you get that many attacks per day with a pain-free interval, that is definitely suggestive of a paroxysmal hemicrania only. So, like as far as the frequency is concerned, you cannot tell anything in hemicrania continua because it's a continuous headache. On top of that, you'll get superimposed jabs. As far as Sun CT is concerned, it can vary from 1 to 200 per day. That's really bad. But the duration of the attack will be in seconds most of the time. If you get a shooting kind of a pain, burning kind of pain, more goes towards a Sun CT only. And next, coming to the triggers for the headache. The most important triggers are sleep, alcohol, very, very important triggers for cluster headache. And we have one more trigger, that is cutaneous trigger. Cutaneous means touching, blowing hot air. So these kind of cutaneous sensory triggers, whether it is there or not. So as far as sleep is concerned, sleep is a very important trigger as far as cluster headache is concerned. Alcohol is a very important trigger as far as cluster headache is concerned. And cutaneous trigger is usually not there in the setting of a cluster headache. Then nothing, these are not usually triggers for your other types of headache. Not triggers, but more importantly, what you need to know is the cutaneous triggers. That is very classical of a Sun CT, which means this touching, blowing hot air, all these things are basically triggers for Sun CT, but that is not trigger for cluster headache. But sleep and alcohol are very important triggers for cluster headache. Then finally, indomethacin response. And this is a very important differentiating point, because indomethacin responsiveness will differentiate each and every different types of headaches. For example, indomethacin responsiveness is not seen with your cluster headache and your Sun CT. But this is a very, very important feature of a hemicrania group. Both hemicrania continua as well as paroxysmal hemicrania are going to be highly indomethacin responsive. Even a single dose of indomethacin will completely abort or reduce the headache. So that's a very good drug to give in these guys. But cluster and Sun CT will not respond to your indomethacin basically. And this is one of the important differentiating points as well as far as headache is concerned. So in trigeminal autonomic cephalgia, the final take-home point, what are things that will give you a differential diagnosis? Number one, type of the pain. If you have a more shooting type of a pain or a burning type of pain, go towards Sun CT. And second thing is we need to know the duration and frequency, or whether you have a pain-free interval or not. Pain-free interval, if it's not there, it will tell you it's more of a hemicrania continua. Duration and frequency will help you differentiate between cluster versus paroxysmal hemicrania in exam, where more duration, lesser frequency for cluster, lesser duration, more frequency for paroxysmal hemicrania. And finally, don't forget the sleep and alcohol as a trigger for cluster and cutaneous trigger for Sun CT, and indomethacin responsiveness is very important for hemicrania group. Both paroxysmal hemicrania and hemicrania continua will respond to indomethacin very, very nicely. So these are the points that you have to note when you think about a TAC in exam. But remember, all the TACs are basically going to happen in the ophthalmic nerve distribution, especially in the trigeminal nerve distribution, especially in the ophthalmic nerve distribution. They are side-locked headaches, and they are going to definitely have autonomic symptoms, and that will be present on the site of the headache more often. And it's a natural tendency to confuse that sun CT with trigeminal neuralgia because of the burning and shooting pain you develop. So now we attempt to differentiate this sun CT versus trigeminal neuralgia. So sun CT, basically you're going to have a shooting kind of a pain or a burning kind of a pain. The same thing can happen in trigeminal neuralgia also. You can have a shooting kind of pain or a burning kind of a pain. And second common factor is the fact that both will have a cutaneous sensitivity, cutaneous trigger that can be exhibited by trigeminal neuralgia. Also, even trigeminal neuralgia can be exacerbated by touching or blowing air across the face. But now the differences. We know sun CT is going to be more in the ophthalmic mode distribution, but yes, trigeminal neuralgia is going to be more in the 5-2 and 5-3 distribution, which means this will be more of a facial pain. The patient will be more complaining of a facial pain rather than a headache. If you have here, it's a natural tendency for the patient to complain that they have a headache. If you have here, the patient usually will be telling more of a facial pain rather than a headache. And at the same time, autonomic symptoms. The best the thing that can differentiate it is autonomic nervous system features, which will be definitely there in the setting of sun CT, which will not be there in the setting of a trigeminal neuralgia for sure. And then the number of attacks, the duration of attack is somewhere around 1 to 600 seconds. It will be for less than 1 second, which means it's like a lightning kind of a situation, like where they cannot really tell the duration. It will just come and goes. And talking about a carbamazepine response. Carbamazepine response, usually the patient can have some resolution of symptoms, but usually it will be incomplete response. Where in the setting of a trigeminal neuralgia, you'll have a complete response to carbamazepine. Complete response. Very important point. So that is why in exam, you know very well. So if they ask you drug of choice for trigeminal neuralgia, of course, everyone hates that drug of choice, but still, if somebody asks you the drug of choice for trigeminal neuralgia, you're going to typically answer carbamazepine as the drug of choice. Then after that, you have a lot of drugs are there. Many other drugs are used in treating trigeminal neuralgia. In fact, trigeminal neuralgia will show reduced response to carbamazepine after a period of time. So we're needing to do some interventions like gamma knife surgeries or probably even glycerol ablation of the trigeminal ganglion. So a lot of procedures are there, but that's beyond the scope of the current discussion. But in exam, only one drug, that is carbamazepine for trigeminal neuralgia. Suppose if they ask for sun CT, what do you answer? What is the treatment? It's an incomplete response with carbamazepine. What will be the treatment for sun CT? So basically speaking, it's one of the most difficult headaches to treat, which means it's not going to respond to any one particular drug. So you're going to see which drug is going to have responsiveness. You're going to use any drug. So you can use lamotrigine, you can use lignocaine, you can use topiramate, you can use gabapentin, you can use carbamazepine, you can use pregabalin, whatever drug you want you can use. But basically, among all these drugs, this lamotrigine is having the better response. Around 45 to 55% of the patients generally responds to lamotrigine. So that's one point that you need to know. Apart from that, all the other drugs have reduced responsiveness. So in exam, if you want to, you can answer lamotrigine as a better choice. But nevertheless, yeah, lignocaine topical. And to abort acute attacks also, lignocaine, to reduce the symptoms suddenly, IV lignocaine also may be tried, but more often we use a topical lignocaine only. So lamotrigine has a better response in this kind of a scenario, 45 to 55%. So you can answer lamotrigine in this situation in exam if they ask. But of course, you know, now paroxysmal hemicrania and hemicrania continua, there is no doubt about that. We are going to use indomethacin only. So without a doubt, because this is going to show the best response, we have studied already. But what about cluster headache? We have not discussed the treatment of cluster headache, which is completely distinctive. Sun CT, lamotrigine fine. Paroxysmal hemicrania and hemicrania continua, we talked about indomethacin. And for trigeminal neuralgia, we studied about carbamazepine. But what about cluster headache? Cluster headache, first aborting acute attack, because it's going to be there for around like a nice 2-3 hours cluster headache. So you have to abort first. The best abortifacient agent is 100% oxygen. You're going to use 5 to 6 liters per minute. For 15-20 minutes, will abort more than 95% of the attacks. So it's a very good option, 100% oxygen. Suppose if 100% oxygen you don't want to use, or if it's not available in emergency scenario, you can use triptans. They're good. Even if triptans are not available, then you can use NSAIDs. Okay. But even if you don't have NSAIDs, then I think you're not working in a hospital. You're working somewhere in a IT company. So even there, I think you have NSAIDs for sure. So any one of these three drugs can be used. Of course, the top of the chart is going to be the 100% oxygen only. But for prophylaxis, what are the drugs you can use? Prophylaxis, currently CCBs are considered to be the best choice, especially verapamil. Are considered to be the best choice for prophylaxis for cluster headache. And apart from that, you can use lithium, you can use glucocorticoids like prednisolone. All these things have shown efficacy, but of course, we know the drug with lesser side effects among the three is going to be calcium channel blockers only, verapamil. That's a better drug, basically. Clear? So I think this much must be enough for the headache. I think we have discussed about each and every different type of headache in detail. Clear? Any doubts? Okay, cool. So I think we have completed the headaches, and I think this much must be enough for understanding headaches. Fine. So I think you can apply all this into your questions. So your questions must be much easier from now on. Of course, this is like a express session only. So I told whatever is possible I have told in this session, importantly today. And hereafter I will, even initially, once I pick up the speed, like it's very difficult to control me. Even I'm going to go in a much faster way from now on. So get ready for the power pack session. I'm going to come back on when? Day after tomorrow again. So that is 27th. Till that, good night. Stay safe. Take care. Bye-bye. And thank you, Hari. Thank you. Bye-bye. Thank you, everyone. Thank you, everyone, for your wishes. Thank you. Thank you. Thank you. I will just close the session. Thank you very much. Thank you very much, everyone.